Hello everyone. So today we are going to look at the chemistry of hemoglobin and try and answer a few important questions. So first, what is hemoglobin? Now hemoglobin is a type of protein, and if you look at the classification of protein, it comes under type of conjugated protein. So what do we mean by conjugated protein? So conjugated proteins are proteins which contain, apart from protein, also a non-protein part. Okay. So if you see over here, this alpha 1, alpha 2, beta 1 and beta 2, these are the globin part of hemoglobin. That is, it forms the protein. These are the protein parts. Whereas the heme which is attached to these globin chains or polypeptide chains, these are the non-protein parts. Okay, so hemoglobin basically is a protein which consists of a protein part which are the globin polypeptides, which are alpha 1 and alpha 2, beta 1 and beta 2, and also the non-protein part which is the heme. Okay, now this heme basically is a colored compound. Okay, that is why it is also called a hemoglobin is also known as a chromoprotein. Okay, it's a colored protein. We all know that hemoglobin has a red color. So this red color is because of the presence of heme. Secondly, heme we all know contains iron. Okay, and iron is a metal. So hemoglobin also is classified as metalloprotein. Okay, so hemoglobin is a conjugated protein, consists of a protein part which is the globin, which are the globin chains, whereas the non-protein part which is the heme. And because heme is a colored compound as well as it contains metals, hence it is also known as chromoprotein or metalloprotein. Now next is what are the important functions of hemoglobin? So there are mainly two important functions. First is transport of blood gases, that is transport of oxygen and carbon dioxide. Okay, oxygen we all know from lungs to the peripheral tissue, and carbon dioxide reverts from the peripheral tissue to the lungs. Okay. And secondly, hemoglobin also acts as a blood buffer. Okay, and it tries to maintain the pH. So we'll see that. Okay. Next, let us look at what is the structure of hemoglobin and how does the structure of hemoglobin help in its function, that is transport of blood gases as well as maintain the or act as a buffer. Okay, now we know hemoglobin, as told earlier, it is made up of heme as well as globin. Globin is the protein part, heme is the non-protein part. Okay, now if you look at this structure of heme, okay, so this is the structure of heme. Now this heme consists of four pyrrole rings. Okay, four pyrrole rings and one iron atom at the center. Now this iron atom basically is in the ferrous form. Okay, Fe plus 2. So heme basically consists of four pyrrole rings and iron atom at the center, which binds with the nitrogen atom present in the four pyrrole rings. Okay. The valency of ferrous here is 6. So if you can see, four valencies are satisfied by the nitrogen which is present in the pyrrole rings. So there are four pyrrole rings present in heme, so four valencies are satisfied. The next one is it binds with the proximal histidine amino acid which is present in the globin chains. Okay, so these globin chains. Okay, so the histidine amino acid which is present in the globin chain, the proximal histidine, one ion on the one valency is satisfied by the proximal histidine. Then we have also a distal histidine amino acid which is present in the globin chain. Okay, so iron again binds with the distal histidine amino acid. Okay, now this excuse me. Now what happens is, in case when the hemoglobin is not oxygenated, then here a water molecule comes. However, under conditions of oxygenation, this is replaced by oxygen atom. Okay, so if you look at the structure, one heme is binding with one oxygen molecule. Okay, so that is why there are four heme groups. So each hemoglobin can carry four oxygen molecules. Okay, each oxygen molecule is binding to one heme. Okay, and the ion which is binding with the oxygen molecule which is binding to the ion which is present in the heme. Okay. Also, because of the presence of this histidine amino acid, the hemoglobin also acts as a buffer. This histidine amino acid, it combines with H positive ions and it acts as a buffer. That means it will try and resist a change in the blood pH and try to keep the blood pH constant. Now we should also know there are two forms of hemoglobin. Okay, one is the T form or the taut form, and the other is an R form or the relaxed form. So what do we mean by taut form and what do we mean by relaxed form, that we should know. Okay. So this is again a simplified structure of hemoglobin, which consists of 4 polypeptide chains, 2 alpha chains and 2 beta chains. Okay. Now we have T form or a taut form that is seen in deoxygenated hemoglobin. Okay, whereas the oxygenated hemoglobin consists of R form. Okay, so why is T form, what is known as T form, and R form is known as R form? Because in T form you have the presence of these salt bridges or bonds which are in between the polypeptide chains and between alpha and beta polypeptide chains. So these salt bridges or bonds is what makes the hemoglobin taut. Okay, and this is seen under deoxygenated condition. So deoxygenated hemoglobin has salt bridges, and that is why it is known as taut form. Okay, whereas the oxygenated hemoglobin, all these salt bridges are broken and it is relaxed and it binds with oxygen. It is binding with 4 molecules of oxygen. So R form is known as relaxed form. Okay. Also, presence of H positive ions, carbamates, that means carbon dioxide combining with hemoglobin, and 2,3-BPG, these stabilize this taut form, okay, or the deoxygenated form. Okay. Now the conversion of deoxygenated form to oxygenated form is with the help of binding with oxygen. Okay. When the first molecule of oxygen binds, okay, one of the salt bridges are broken, and once the first salt bridge is broken, okay, there occurs rearrangement between the globin chains in such a way that it favors binding of another oxygen molecule. Okay. So binding of one oxygen molecule favors the binding of other oxygen molecule such a way that the T form is converted to R form. Okay. So this type of binding, in which binding of one oxygen molecule favors the binding of other oxygen molecule, is known as positive cooperativity, okay, or positive allosteric effect, okay, which is very, very important. And because of this positive cooperativity, we have a sigmoid shape of oxygen dissociation curve, okay, that we will study later. Okay, so we have two forms. T form is the taut form, which is the deoxygenated form because it has salt bridges, and R form is the relaxed form. It does not contain salt bridges, and it is the hemoglobin which is binding with the oxygen. Okay. Now, before we go into the functions of hemoglobin, let us see what are the types of normal hemoglobin which is present in us. Okay. First is the adult hemoglobin or hemoglobin A. Okay. So the adult hemoglobin, the correct denotation is HbA. Okay. So adult hemoglobin consists of 2 alpha chains and 2 beta chains. Okay. We have seen previously, see, it consists of 2 alpha chains and 2 beta chains. Okay, this is the normal adult hemoglobin. Okay. The other type of normal hemoglobin, which is present in us is hemoglobin A2, which also consists of 2 alpha chains, but instead of beta we have 2 delta chains. And similarly we have hemoglobin F or fetal hemoglobin, which consists of 2 alpha chains and 2 gamma chains. Okay. So we have 3 types of hemoglobin: hemoglobin A, hemoglobin A2 and hemoglobin F, which are all having 2 alpha chains, but there is difference in beta chains, delta chains and gamma chains. Okay. So if you look at the normal range of adult hemoglobin, okay, so hemoglobin A is the commonest, so it has maximum percentage, at least 96% of hemoglobin A is present in a normal adult individual. Okay. Whereas hemoglobin A2 is roughly between 2.5% to 3%. Okay, and hemoglobin F is less than 1%. The hemoglobin A, it is a major hemoglobin present. It performs all the functions of hemoglobin, and if the percentage of hemoglobin A is reduced, then it signifies that the patient is having patient may have some kind of hemoglobin abnormality or hemoglobinopathies, which we will see in subsequent lectures. Now, hemoglobin A2 is very, very important for one sake, that the normal range of hemoglobin A2 is 2.5 to 3%. Okay. Now, increased level of hemoglobin A2 suggests that there is also an abnormal type of hemoglobin or hemoglobinopathy. Okay. So, it forms hemoglobin A2, it forms pair with alpha chains. Okay, so delta chain is there, it forms pair with alpha chains and forms hemoglobin A2. Now, what is interesting to note is that if the hemoglobin A2 level is increased to 4 to 8 percentage, okay, that signifies beta thalassemia trait. Okay, an isolated increase of hemoglobin A2 between 4 to 8%, even if the individual is not having any symptom, is suggestive of beta thalassemia trait. In other words, how do we diagnose beta thalassemia trait? By measuring hemoglobin A2, and if the hemoglobin A2 is between 4 to 8%, then it is suggestive that the person is having beta thalassemia trait. Okay. Next is hemoglobin F. So hemoglobin F is having very small percentage, less than 1. However, increased percentage up to 90%, sometimes even more than 90, is seen in beta thalassemia major. Okay, why that happens, that we will see in the next lecture. Okay. Now, shift from hemoglobin F to hemoglobin A occurs maximum by 6 months of age, or sometimes up till 1 year. Okay, so when the newborn is born, okay, so he is having hemoglobin F, major hemoglobin present is hemoglobin F, but by 6 months of life, all the hemoglobin F is converted to hemoglobin A, or sometimes it might even extend up to 1 year. Okay, so at this normal level of 1% is seen from 6 months to 1 year onwards. Another type of normal hemoglobin which is present is glycated hemoglobin, okay, HbA1c. Okay. Now, A1, when the hemoglobin A1 is there, so A1 denotes that hemoglobin is glycated. That means it's an addition of glucose is there, an addition of sugar is there. Okay, so basically this addition of sugar is non-enzymatic, so that is why it is glycated hemoglobin. Okay, so this is again a normal type of hemoglobin. It consists of 2 alpha chains and 2 beta chains. However, to this beta chain, glucose has been added. Okay, glucose binds irreversibly, so this becomes a glycated hemoglobin. Okay, and its normal range is less than 5.6%. Now, what is the significance of HbA1c? HbA1c nowadays is used for diagnosis, prognosis, and management of diabetes mellitus. Okay, so how HbA1c is used to diagnose diabetes mellitus, that we will see later. Okay, a value of HbA1c more than equal to 6.5% is diagnostic of diabetes mellitus. Okay, and also it helps in the prognosis. If the HbA1c is on the higher side, 10, 12, more than that, that signifies that the patient's blood glucose is not under proper control and he is having high blood glucose levels for a long time, and that can lead to complications of diabetes. So the prognosis is bad, and also we use the amount of HbA1c which is present to manage diabetes mellitus. That means when we start treating diabetes mellitus, we want to see that the percentage of HbA1c is appropriate, okay, as per required. Then we have other types of normal hemoglobin. Those are embryonic hemoglobins, okay, Gover 1, Gover 2, and Portland. So these are seen in the first trimester of fetal life. Okay, so these are the types of normal hemoglobin, adult hemoglobin, hemoglobin A2, hemoglobin F, and HbA1c. Okay, that you should remember. Now, why hemoglobin is considered as an ideal respiratory agent? Okay, first, it can transport large amount of oxygen. Okay, that we will see. It has great solubility. It can take up and release oxygen at appropriate partial pressure, and it acts as a powerful buffer. So these are the criteria, these are the essential characteristics which make hemoglobin an ideal respiratory agent. Now let us look at oxygen transport by hemoglobin. Now if you see over here, lungs, the oxygen is transported from lungs to periphery, Okay, and the hemoglobin is responsible for this transport. Now, if you look at lungs, the partial pressure of oxygen in the lungs is roughly about 100 mm of Hg, whereas at the peripheral tissue, the partial pressure of oxygen is around 40 mm of Hg. Okay, now let us look at the comparison in which we have two proteins. Okay, here we have this graph is that of hemoglobin, whereas this is that of a myoglobin. Okay, so myoglobin also is a type of protein which contains heme and which binds with oxygen. Okay, so myoglobin is present in muscles. It is used to store oxygen so that muscles can contract. Okay, so let us look at the functions of myoglobin and hemoglobin, how it is different. So at lungs we have the partial pressure of oxygen is roughly it's around 100 mm of Hg. Okay, so if you see over here 100 mm of Hg, here the hemoglobin is roughly or myoglobin is roughly 90 to 100% oxygenated. Okay, saturated. So this is the hemoglobin curve and this is the myoglobin curve. So if you look at the hemoglobin curve at 100 mm of Hg, that is in the lungs, it is roughly 90 to 100% saturated. Okay, now let us look at the saturation at the tissue level. Now tissue level, at the peripheral tissue level, the partial pressure of oxygen is 40. Okay, so at partial pressure of oxygen 40, if you look over here, the hemoglobin is around 60% saturated, whereas the myoglobin is similar, roughly around 90% saturated. Okay, so a dip in the partial pressure of oxygen, okay, from lungs to the periphery in the tissue does not make a difference in myoglobin. Okay, whereas in hemoglobin, the saturation of hemoglobin decreases from 100% to 60%. That means 40% of hemoglobin has been given to the tissues. Okay, so 40% of oxygen has been given to the tissues. Okay, so 40% of oxygen has been lost. Okay, so 40% of oxygen has been taken up by the tissues. That is what we want. Okay, so hemoglobin is an ideal, that is why hemoglobin is an ideal respiratory agent as compared to myoglobin. Even at the partial pressure of oxygen present at the tissues, the myoglobin is not releasing any oxygen, whereas at the same partial pressure, the hemoglobin has lost oxygen. Okay, that is what we want. We want the tissues to take up oxygen. Okay, so 40% saturation, there is a dip of roughly around 40% saturation. Okay, now if let's see if the partial pressure decreases further, okay, especially let's say in muscles. So when it is actively contracting, there the partial pressure of oxygen is further reduced. Then the myoglobin starts to dissociate oxygen so that the muscles can start use that oxygen for contraction purposes. Okay, so that is the difference between myoglobin and hemoglobin. Okay, now why this difference in oxygenation, loss of oxygen is there? Okay, this is because of the positive cooperativity that is seen with hemoglobin. Okay, so hemoglobin has a quaternary structure having four polypeptide chains, so in which binding of one oxygen molecule favors the binding of another oxygen molecule. So because of that, we have this type of sigmoid shape, and because of this sigmoid shape, okay, it ensures that when the partial pressure is of the tissue is reduced, then significant amount of oxygen is given by the hemoglobin to the tissues, or significant of unloading of oxygen has been done by the hemoglobin. Now let us look at the situation in which, let us assume this, now we are concentrating on only on the hemoglobin curve. Now let us assume that this curve is shifted towards the right side. Okay, now at the same partial pressure at the tissue. Okay, so earlier the saturation was around 60%. Now if the oxygen dissociation curve shifts towards the right side, the saturation of hemoglobin is 40%. That means more amount of oxygen has been unloaded. Okay, so 60% has been unloaded. Okay, similarly, if we shift this oxygen dissociation curve to the left side, you can see over here, earlier the saturation at the tissue level was 60, and now it increases to roughly around 80. Okay, so in other words, when we shift this oxygen dissociation curve towards the right, the unloading of oxygen takes place. That means hemoglobin loses oxygen so that it can be given to the tissues. And if the oxygen dissociation curve shifts towards the left side, then the hemoglobin does not unload oxygen easily. Okay, so the affinity of oxygen and hemoglobin is increased. Okay, it does not give out oxygen easily. Okay, this is what we should have to remember. So this is known as oxygen dissociation curve, which explains the loading and unloading of oxygen. Okay. Now let us look at the factors which affect the oxygen dissociation curve. A shift to the right indicates oxygen unloading. That means the hemoglobin is giving out oxygen to the tissues. A shift to the left means oxygen loading. It is not giving out, it is conserving oxygen. So what are the factors which affect the oxygen dissociation curve? Okay, first is the pH or carbon dioxide, and the effect of pH and carbon dioxide on the oxygen dissociation curve is known as Bohr effect. Okay. Now this is what happens in Bohr effect. When there is increase in carbon dioxide or increase in H positive ions, there occurs a shift of oxygen dissociation curve towards the right, as we have discussed. Okay, and this is known as Bohr effect. That means the effect of pH and carbon dioxide on the oxygen dissociation curve. So if there is increase in H positive ions or decrease in pH, the oxygen dissociation curve shifts towards the right. Similarly, when there is decrease in carbon dioxide or decrease in H positive ions, there is a shift of oxygen dissociation curve towards the left. Okay, so if you see over here, when the pH is 7.2, the oxygen dissociation curve shifts towards the right, and when it is 7.6, it shifts towards the left. Okay. Similarly, in case of 2,3-BPG, okay, now 2,3-BPG is an intermediate of glycolysis. Okay. Now when 2,3-BPG is increased, again, oxygen dissociation curve shifts towards the right, and when 2,3-BPG is decreased, it shifts towards the left. Okay, so that is seen in case of fetal hemoglobin. And 2,3-BPG is increased, which that means the oxygen dissociation curve shifts towards the right. That is seen in cases of altitude. Okay, so when we go to high altitude, there is increased production of 2,3-BPG, which shifts the oxygen dissociation curve towards the right, so that more oxygen unloading from the hemoglobin takes place, and the tissues can get oxygen, okay, at high altitude levels. Similarly, we have so let us see what are the factors which help us to adapt at high altitude where the oxygen concentration is less, blood pressure is less. One is the RBC concentration increases. So if the RBC concentration is increased, hemoglobin concentration is increased, then more binding of hemoglobin and oxygen takes place, and that can be delivered to the tissues. Similarly, hemoglobin concentration increases, synthesis of 2,3-BPG increases. Now when synthesis of 2,3-BPG increases, we have seen that oxygen dissociation curve shifts towards the right. Okay, so there is increased unloading of oxygen from the hemoglobin that can be given to the tissues. In case of fetal hemoglobin, there occurs shift of oxygen dissociation curve to the left. Now adult hemoglobin consists of 2 alpha and 2 beta. Okay, fetal hemoglobin consists of 2 alpha and 2 gamma. Now 2,3-BPG does not bind to gamma chain, hence unloading of oxygen is less. Okay, so 2,3-BPG, in order to function, how does it cause unloading of oxygen? Because it binds to the beta chain. Okay, now in fetal hemoglobin, in the fetus, there is no beta chain. In the fetus, there is hemoglobin is fetal hemoglobin, so which is having gamma chains. So if there is gamma chain, the 2,3-BPG cannot bind to the gamma chain. So if it cannot bind to the gamma chain, the fetal hemoglobin does not lose oxygen easily. Okay, so this helps to carry the oxygen which is required. Okay, effect of temperature. As you see, as the temperature increases, okay, 20 degrees, the oxygen dissociation curve was here. As the temperature increases, 38, 43, the oxygen dissociation curve or ODC curve shifts towards the right. Okay, that leads to unloading of oxygen. Now, what is the biochemical basis of oxygen transport? Okay, now let us see over here. Now this is at the tissue level, the carbon dioxide, it is generated by metabolism, it goes inside the RBC, it combines with water to form as carbonic acid. Now this carbonic acid dissociates into H positive ions and bicarbonate ions. Okay. Now this H positive ions will decrease the pH. Okay. Now when there is decrease in pH, we have seen that oxygen dissociation curve shifts towards the right according to the Bohr effect. Now when oxygen dissociation curve shifts towards the right, okay, there is increased unloading of oxygen to the tissues. So hemoglobin, which was coming from the lungs, it is carrying oxygen, and because under conditions of acidosis or increased H positive ions, the oxygen is lost. Okay, and as a result, the hemoglobin buffers the H positive ions which are generated. So the H positive ions, it buffers the hemoglobin. Now how does hemoglobin buffer the H positive ions? With the help of histidine groups. Okay. Also the carbon dioxide which is produced. Okay, so this carbon dioxide also binds with hemoglobin directly and forms a carbamates. Okay, so this carbamates also stabilizes the T form or taut form that we have seen. Okay, so now the hemoglobin is deoxygenated, so this salt bridges form. Okay, that is initiated by the carbamates, and the salt bridges begin to stabilize. Okay, so also there is acidosis. So acidosis also leads to synthesis of 2,3-BPG. So this also stabilizes the T form of hemoglobin. Okay, so up till now what is happening is, because there is increased respiration, increased formation of carbon dioxide at the tissue, so it is leading to formation of H positive ions, which is causing acidosis. So under conditions of acidosis, the oxygen dissociation curve shifts towards the right, so hemoglobin loses oxygen, oxygen is lost. This H positive ions is buffered by the hemoglobin. Okay, and the deoxygenated hemoglobin, now it forms T form of hemoglobin or taut form of hemoglobin. Now this T form is stabilized with the help of increased formation of 2,3-BPG, which is seen, and formation of carbamates. Okay, so as we have seen in earlier, what are the factors which stabilize T form? Those were your carbamates, 2,3-BPG. Okay. So similarly, you can see over here, carbon dioxide which is produced goes inside. Okay, same thing, H positive ions is buffered and bicarbonate is formed. Now this bicarbonate which is formed, it goes outside the RBC, and chloride goes inside the RBC. Okay, which is called chloride shift or Hamburger effect. Okay, this is known as chloride shift. Now why chloride goes in? To maintain the same charge. Okay, when bicarbonates are going out, chloride is also a negative charge, it moves inside. Okay, to maintain electroneutrality. Okay, now this hemoglobin which is buffered, okay, deoxygenated hemoglobin, it again goes to the lungs. Okay, so it lungs, the oxygen, it binds with this hemoglobin. This oxygen breaks the salt bridges which are formed, and the H positive ions are released. Okay, and again formation of carbonic acid is seen. Okay, so H positive ions are released, H positive ions combine with the bicarbonate which was transported. Okay, you can see over here. So the H positive ions are released, the bicarbonate ions which had gone out over here, extracellular, again goes inside the RBC, it combines with H positive ions and forms this carbonic acid. Carbonic acid dissociates into water and carbon dioxide, and this carbon dioxide is exhaled out. Okay, so this is how the oxygen is transported from lungs to the periphery, and from periphery again back to the lungs, how the carbon dioxide is exhaled out. Okay, so this is how the hemoglobin does the transport of oxygen. Okay, so I hope you have understood. Okay, so thank you very much, and I will see you soon.